Hello everyone, I'm Ali Yıkılmaz. I'm a pediatric radiologist at McMaster Children's Hospital. I'm going to talk about intussuception in this lecture. Intussuception means telescoping of bowel segments into each other, or invagination of one segment into the distal segment. And the part that goes into the other bowel is called intussusceptum, and the recipient bowel is called intussuscipiens. And the bowel does not invaginate by itself, but it invaginates along with its mesentery and vasculature, and this causes obstruction of the bowel as well as obstruction of the vasculature and bowel ischemia, and it may have catastrophic results. And it's a very challenging entity among pediatric radiologists, diagnostic pediatric radiologists. We mean ileocolic intussusception unless we mention otherwise. It is a very popular provisional diagnosis in ER, but not very few of them are positive. 90% of them are idiopathic. They usually occur secondary to uncoordinated peristalsis or lymphoid hyperplasia, usually associated with viral infection, and it's usually a complication of a ongoing viral infection. 75% of them occur under 2 years, and 40% of them are between 3 to 9 months in Toronto. It's not seen in the newborns up to 3 months. Peak months are January, July, and in Toronto, busiest on May, June, and July. There are approximately 35 cases per year in Toronto, and our number is way lower in Hamilton, around 1 case a month in average, but they come as groups. Sometimes, some months we don't see any cases, some months we see 5, 6 cases. The clinical presentation is typical severe crampy abdominal pain alternating with periods of no pain. Rectal bleeding usually occurs once after ischemia occurs. Red gel-like stools mixed with mucus. There is a lead point in 5 to 6% of the cases. The lead point can be diffuse annexation purpura, cystic fibrosis, or focal, such as Meckel's diverticulum polyp, duplication cyst, lymphoma, appendix, enlarged mesenteric lymph nodes, or lipoma. The mortality rates are declining over years, most likely secondary to advances in ultrasonography and surgery. Ileocolic intussusceptions require urgent reduction due to the risk of bowel necrosis. I don't know why they usually arrive at 2 a.m. in the morning, and a patient who arrived at 2 a.m. cannot wait until morning for a reduction. When we talk about intussusception, we mean ileocolic intussusception. It is relatively common, and there's a lead point in a few group of patients. And another entity is colocolic intussusception. The small bowel is not involved, it's within the colon. It's rare and associated with cystic fibrosis most of the time. The ultrasonographic findings are similar to ileocolic intussusception. The treatment is similar, reduction by radiology, and if the reduction fails in these two groups, they undergo surgery. However, there is this small bowel to small bowel intussusception. It is common, encountered frequently in daily ultrasound practice, usually have no clinical significance. They are most of the time discharged or observed. Some surgeons prefer to do a follow-up ultrasound before discharging to reassure, but I've never seen any patients having problems secondary to a small bowel to small bowel intussusception. There is an exception to this. Small bowel to small bowel intussusception with a lead point. It's rare. However, the clinical presentation is remarkable with acute abdominal obstruction. These patients usually go to surgery due to their acute clinical presentation. I mean, more severe than the regular ileocolic intussusception. We usually do a CT and these patients directly go to surgery. So it is usually very easy to differentiate between these two. The sonographic findings are similar. We can see in the small bowel to small bowel intussusception, ileocolic intussusception, colocolic intussusception, and a small bowel to small bowel intussusception here caused by a lipoma is the lead point, and we can see a long segment of small bowel to small bowel intussusception. So when there is intussusception, most of the time we can see some mesenteric lymph nodes along with the bowel, and here there is this bowel as the intussusceptum, some mesenteric fat and lymph nodes, and we try to look for any lead points in this region. This this video is to show you an intussusception reduction surgically. So you see the manual reduction. Here is the distal ileum, and this part is the colon. So they are basically milking the bowel. And here it came off. You can see the cecum and the appendix coming off. So the bowel looks healthy, treated. This is actually what we are trying to avoid by doing reductions. We don't want this surgery to happen. And how do we see it? So it's typically, there is this ultrasonographic appearance in the right upper quadrant. It's called target sign or pseudokidney sign or donut sign, crescent in a donut, or bullseye sign. So it is just the intussusceptum and intussuscipient. There is the thickening of the intussuscipient and some mesenteric fat, some lymph nodes. You can see an appendix, you can see a Meckel's diverticulum in it, or a lipoma or a polyp. We put some color on it to see if there's still some vascularity going on and the bowel is not necrotic. It rarely happens. There's usually some fluid, and on the X-ray, the diagnosis is confirmed by not seeing any gas in the cecum. So there is no gas, and you can even see the opacity caused by the intussusceptum within the transverse colon. So the findings are typical. This is usually a large mass, 3 centimeter. When there is intussusception, there is no gas anymore. So it's, as you can see here, if there's gas, it's not intussusception, and it's very unlikely to miss an intussusception secondary to gas. So if you're not seeing the bowel nicely due to gas, it's not intussusception. Just a note, small bowel intussusceptions are common and incidental, no need to do a reduction. So how do we differentiate ileocolic and small bowel? Because they are the most common ones and causes problems during the colds. So there are many ways to differentiate them. We can reliably differentiate them. I will go one by one. First, clinical and laboratory findings. Ileocolic, small bowel. So age really helps. Usually under 3 years, small bowel. This can be under 3 years or older, like in a 15-year-old, when doing an ultrasound for a urinary tract infection, you see this, it's small bowel. Crampy abdominal pain. Clinical presentation is typical. Small bowel intussusceptions are usually asymptomatic or non-specific abdominal pain. There is abdominal distension, no abdominal distension. Palpable mass, no palpable mass. Blood in stool. It's either visually or in the lab. There's almost always blood in stool, and there is no blood in stool. and this is a very good discriminator. Leukocytosis is also common in ileocolic and no leukocytosis in small bowel. Other than location is also very helpful to differentiate between ileocolic and small bowel intussusceptions. Ileocolic intussusceptions always starts from the ileocecal junction. So if you see a normal ileocecal junction, so you know that it is not ileocolic anymore and it's small bowel. And it follows the course of the colon. It may be just in the ascending colon, or it may be transverse, it may progress, even it may go out of the rectum in very severe cases. So we see it in the course of the colon. But most common location is right upper quadrant or the transverse colon. In the small bowel one, they don't really follow the course of the colon and could be anywhere in the abdomen in any quadrant. Size is important. Usually ileocolic ones are large. In the diameter is more than 3 centimeters, and small bowels are usually under 2. There may be some occasional overlaps between the size, but it's usually reliable. Also, the involved segment is important. It's usually a very long segment in the ileocolic ones, depending on how far it goes down the colon. So it is usually not a few centimeters, but small bowel is usually a few centimeters. It can be longer, but most of the time it's a short segment involved. One of the most important things is peristalsis. So ileocolic intussusceptions are obstructed. There is no peristalsis anymore. It's stiff like a mass. It doesn't move at all. But in this small bowel intussusception, you still see peristalsis. The bowel is moving, so you can confirm that there is no obstruction of the bowel. So if there is no obstruction, there is no clinical significance. Other sonographic findings are also helpful. In the ileocolic ones, there's usually lymph nodes within the intussusception. In the small bowel one, no lymph nodes. There's always overlaps, but usually. The fat core is usually large. In the small bowel, we can see fat core, but it's usually small or no fat core. The outer wall is thick, outer wall is thin comparatively. So this is thicker, this is thinner, but they are both thickened. And there's usually some free intraperitoneal fluid, but there is no intraperitoneal fluid in the small bowel ones. So all these features help to differentiate between ileocolic and small bowel intussusception. Most patients benefit from reduction even with a lead point. And patients with signs of bowel ischemia or in clinical condition directly go to surgery. This is important because it really doesn't matter if the patient has a lead point. We usually do the reduction, even if sometimes we see a lymphoma, we know that it's lymphoma, but we do the reduction because it's a palliative treatment. There is no harm. Most of the time we try an intussusception, and then if it fails, then the patients go to surgery. So how do we reduce them? There are different ways of reduction. We can use air, we can use liquids, like hydrostatic, just water, tap water, saline, or we can use contrast. It can be water soluble. In the past, they used barium. So basically, we are just doing an enema. It's a simple procedure. We are doing an enema under imaging guidance. We insert a Foley catheter into the rectum. We inflate the balloon. We make sure that the air doesn't come off. And we inflate air with high pressure. So, for example, this is an reduction with air. We started inflating air. Initially, there is no gas in the colon, and we start inflating the gas, so we create a contrast between the intussusceptum and the colon. Here we can see the intussusceptum in the transverse colon, and it goes back into its normal position over time, and initially the air passes into the small bowel, and passage into the small bowel confirms the success of the reduction. In this case, interestingly, we can see this nodular opacity, which turned out to be a polyp, actually. Most of the time, we can't really tell if there's a lead point, but in this one, it was clear. This is an example of reduction with water-soluble contrast. It is not really preferred. Usually it is hydrostatic or air nowadays. So in this case, you can see the anatomy better. This is the intussusceptum at the transverse colon, goes back into its normal position, and we see contrast passage into the distal ileum. Hydrostatic reduction is popular nowadays because it doesn't consist of ionizing radiation. And here you can see a procedure that I did back in Turkey years ago. This is the radiology resident, this is a surgical resident, and this is the patient with the mom. We are administrating saline into the rectum, and we are following up the saline. This is the hepatic flexure, ascending colon, and cecum. Here you can see the saline with echogenic dots in it. It moves, and here is the bowel loop with gas, and here from cecum into the terminal ileum you can see the passage of the saline. This confirms the success of the procedure, and as you can see, the ileocecal valve is swollen and edematous. This is common after intussusception, and we see this commonly after reduction in the fluoro. In the fluoro, it may be confused with a residual bowel, but it's usually just a swollen ileocecal valve. So all of these reduction techniques, hydrostatic or air or contrast, they all have similar success rates, which is above 80%, and under 1% perforation rates. It's a very rare complication that I've never witnessed one. And also, they may reoccur even after a successful reduction, they can come back 20% of the times. And in these cases, we repeat the reduction. And in some cases, we see spontaneous reduction too. And here, bowel perforation as a complication of reduction procedure is rare, under 1%, and if that happens, patients go to surgery anyway. And so we should be careful for the lead points, to detect the lead points. So if the age is not typical, over 2 to 3 years, then you should look for a lead point. For example, in this case, there is this intussusception because the patient was 7 years old presenting with an obstruction. We did further investigation with CT. We confirmed that there was an ileocecal intussusception, and we reduced it. This patient had 3 successful intussusceptions, but with recurrence, and eventually had a surgical resection. And here you can see one of the intussusception reduction procedures, and this is the intussusceptum residual, and it's gone. And now we see air within the small bowel loop, so this is a successful reduction. And look for a lead point above the typical age, above 3 years. Here is an example of a small bowel intussusception caused by lipoma. Here you can see the lipoma, and this is the fatty mesentery of the intussusceptum. Here you can see the invaginated part. And this patient presented with acute abdomen. We thought it was an internal herniation. and quickly got a CT, not an ultrasound, and confirmed that surgery that there was a small bowel to small bowel intussuception. As you can see, the obstruction is very significant. There was no ischemic injury, irreversible ischemic injury yet, and there was a lipoma. Also, juvenile polyps, colonic juvenile polyps are common in children, and they have typical sonographic appearance, and they may cause intussusception, and you should know these typical features to diagnose them. Here is the a typical appearance of the colonic polyp. Because they are in the colon, it's difficult to detect, to identify them. So here they are usually ovoid, less than 2 centimeters, and they have cystic openings, just like this one. They look like ovary, but with an echogenic increased stroma. But they're actually just polyps. And at the peduncle, you can see the vascularity. That's also typical. So if you see this within the intussusceptum, so you know that there's a lead point. There's a polyp causing the intussusception. Here's another example. Patient presents with typical target appearance, more measuring 3.3 centimeter, but on the ultrasound we see this appearance here. It's actually a nodular ovoid lesion with cystic opening. So it turns out to be a juvenile polyp, and we can see the typical vascular pattern in the polyp. Another example of an ileal intussusception caused by Meckel's diverticulum. Here you can see the ultrasound appearances. So this is very different than a casual small bowel to small bowel intussusception. It's long segment, it's large, it looks ugly, the wall is very thickened. On the CT we can see the wall thickening, a lot of free fluid, and let me show you the images better. There is significant bowel obstruction with air fluid levels. The proximal bowel is dilated. And from the get-go, we knew that something catastrophic was happening. This patient didn't spend time for ultrasound, directly went to CT. We did the CT study. We saw the finding here, some bowel wall thickening, bowel ischemia, and free fluid, and the transition point, and patient turned out to have an ileoileal intussusception secondary to Meckel's diverticulum as the lead point. So I told you that the diagnosis of ileocolic intussusception is relatively easy, but you need to know the anatomy and how the bowel looks on ultrasound. I will just show you some sonographic anatomy and some conditions that may be confused with intussusception, although they are very rare. So here is the cecum and the terminal ileum. Cecum you can't really see nicely because there's usually some gas. Because of the gas, there's some dirty acoustic shadowing. It obscures the rest of the cecum. So usually you identify the terminal ileum, it's easier. So you identify the terminal ileum, which is the 2-3 centimeter segment of the distal ileum, then the ileocecal junction, and then you can assume that this is cecum. You can't really see the lumen of the cecum very nicely, but you can see the lumen of the terminal ileum very nicely. The wall, this is a jejunum. You can identify the valvula convolutus, and here you can see the colon with the haustration, and the the thickness of the terminal ileum is no more than 2 millimeters. It's okay to be a little bit prominent, just like this. It doesn't mean that it's thickened. It's usually like this. Up to 2 millimeters is considered normal. So Let me show you the normal TI here too. Here is this, you can see the appendix. It's just above the appendix, and you can see that the wall nicely, no more than 2 mm. And here is a Crohn's patient. You can identify the thickened wall and a narrow lumen with gas in it, and there is no intussusception in these cases. Another one, bacterial ileitis, the terminal ileum is very thickened, irregular, and very hypervascular. You can't really differentiate between these two. Our finding by imaging is just thickening of the bowel. And also this is caused by a parasitic colitis. This is cecum. This is the transverse colon. The entire colon looked like this, caused by entomobia histolytica actually. And the wall is thickened, hyperechoic, as you can see. This is thickened colon. There is no intussusception. Another viral ileitis. Here you can see the appendix, so just above it. So I know that this is terminal ileum, thickened, and some very mild hyperemia. And sometimes on the axial plane, they may look like intussusception, but they're not. You need to make sure that there is no intussusception in these cases. There may be secondary intussusceptions secondary to these infections, though. Finally, there is a different entity of intussusception, G-tube related small bowel intussusception. This is a completely different entity. There is intussusception in the proximal jejunum. These are the GJ tubes. This is the G component in the stomach, and then there is this J component, jejunal component. And the many patients use this for feeding, and they may migrate, they may cause problems. This is one of the complications. And intussusception occurs secondary to the catheter. The catheter acts as a lead point. And here you can see the catheter echogenic with posterior acoustic shadow, and around the catheter, it's usually around the tip, and it starts around the tip coming back, and you can see the intussusception. It's like the target appearance. It's different than all the other ones, and as you expect, if there's normal anatomy, they will appear in the left upper quadrant. So you don't need to check the rest of the abdomen. And the approach is, when there's a problem of the GJ tube, when it's not working, this is the first thing, to do an ultrasound. If there is intussusception around it, so they know why it's not working, it's because of the intussusception, and there is no treatment for this, there is no reduction procedure. We just it was just removed and replaced with a new one. So in the ER, most of the time they ask for intussusception, and this is we just need to check for this. You need to make sure that the sonographers are checking the course of the catheter and find the catheter and show the catheter all the way and make sure that there is no intussusception. If they cannot see the catheter, they can look at the previous radiographs to see where the tip of the catheter is. It may be migrated, the anatomy may be different, there may be malrotation. Or in some cases, because of the gas, they may not be seen. Then in these cases, you just need to scan the left upper quadrant and make sure that there is no intussusception. And here is the intussusception measuring smaller than the ileocolic ones and with the catheter in the center. So GJ catheter-related intussusception occurs at the jejunum around the catheter. Just focus on it. They are not asking for ileocolic intussusceptions in these cases. So, take-home points. Intussusceptions are one of the challenges for diagnostic rats. And ileocolic intussusceptions can be reliably differentiated from small bowel intussusceptions by imaging, clinical, and laboratory findings. Most intussusceptions arise below 3 years old. Look for a lead point above the typical age. And the type of the reduction usually doesn't matter much, hydrostatic versus air. You can do either of it. And Thank you for watching.